One result of our work with Disrupt has been a change in emergency medicine physician approaches and understanding to our patients. That as their doctor in the emergency department, we're there not only to address their chief complaint that brought them into the emergency department, but then to also, again, look at the patient more holistically and consider everything from housing and housing insecurity to medication access to follow-up care, to address the underlying issues that may have brought the patient to the hospital and leaves them at risk for returning to the hospital. I sometimes use the metaphor of an iceberg when a patient presents to the emergency department, and they may come to the ED just saying that they're short of breath or they're having an asthma attack, and that's the little tip that we see above the water. But then underneath the water, it may turn out that they have lost their home nebulizer machine and they need that replaced, or that they're currently homeless and don't have access to some place to receive their treatments, or their PCP is retired and they don't have good follow-up, or they were lost to follow-up with the pulmonology clinic, or they just don't know who to call when they have an asthma exacerbation, and so they just call 911. So the idea of broadening our scope and seeing these patients not just as an individual with an isolated medical complaint, but as a sort of entire individual who has all of these sort of components that make up the cause for an emergency department visit.
Physicians, one of the major things that has changed for us with Bronx Park, and since Bronx Park has become pretty involved with us, it's basically empowered physicians to screen for food insecurity. It was something that we would love to do, but the next question was, once we screen, what do we do? And I think once we started to have this pilot and we started to teach physicians what was out there and teach them that they didn't have to reinvent a wheel, they didn't have to find new resources, the resources were already there. All we needed to do was connect the wheels and have like a fully functional program where we can actually help patients out. So I think one of the things that Bronx Park has definitely done, at least for the physicians, especially the pediatricians here, what has been to empower them to ask those questions and realize, oh, I can do something about it once I screen a patient positive for food insecurity. I definitely saw that light bulb go off for a lot of our physicians. And the best thing you can do for pediatricians is to give them some power, and we will use it.
And so what initially started off as, let's try to identify people who were health home eligible, soon snowballed into a really large social determinants of health project that had us not only getting agreement on what the screener would look like, getting it into Epic, but then also having the staff on the back end who would be able to deal with patients who screened positive. And since April of 2018, when we rolled out the comprehensive tool, we've screened over 25,000 patients so far. We're screening at about 2,000 to 3,000 patients a month across the ambulatory primary care practices. Importantly, in my role as the Vice President of Community and Population Health, we've been able to use the data on these 25,000 screens to hotspot areas. So we understand it not only patient by patient, but we're also starting to understand issues like food security at the census tract level. Frankly, we could do it at the building level. So that helps us look at issues like what is happening in this particular area. Why is this area lighting up for food insecurity? For instance, each of our hospitals is either squarely in or right adjacent to a food insecurity hotspot. And so that starts to beg the question, what can the hospital do to help bring about more resources in its own footprint? Just we're not even talking about having to drive 3 miles down the road. We're talking about right here, right now. What can we do as a health system to augment the capacity of the food providers, the food pantries and others, to be able to handle the food insecurity needs of our patients? And when you think about being able to take social determinants of health issues like that and to map them in that kind of geographic way, it really does add another lever for action.
I think DISRIP is encouraging organizations that have similar missions but are approaching them from different angles, such as St. Barnabas and Bronx Works, and providing an opportunity for those organizations to really work together. And in this case, it's to work together to work with people who have kind of fallen through the cracks and really connect those people to the services they need rather than the services that are most obvious for them to get. So someone who's homeless is cold, they will come into the emergency department because it's warm and they won't necessarily get pushed out right away. But it's not the ideal solution for them. So now we're able to bring two organizations together to connect those people to the services that might really benefit them.
The project was an extreme success, and we're continuing on. And I think that the community-based referral project, the success of it wasn't just in the numbers. The success was showing us that you could have all of the healthcare services in place, traditional services in place, and you could still have gaps in care. And what the pilot showed us was that even with care planning in place, discharge planning in place, patients having their home care set up, we're still finding where the patients are going back to the hospitals, and we were able to recognize a gap in care and actually address it, target it, and be successful in supporting our patients. That's one thing. But what I would really love to talk about is the fact of having a for-profit healthcare organization come and sit down at a table with a hospital, with other organizations, many times our competitors, and really sit and brainstorm. So I think that if you want to really look at DISRIP as a success, I really think the successful outcome of DISRIP is that we've never sat at the table. We work together all the time. I mean, moving patients between us, but what we have never done is come together and work as a single team. And I think that that's what I love about the Bronx Bronx Partners for Healthy Community. I think that experience of working on a pilot together with Bronx Partners has really showed us the ability for organizations to come together as one team and not just working together doing their different parts.
The behavioral health initiative, which I have been involved with and our organization has been involved with from the very beginning, as again a small organization, we were the lead agency for the ADHD exploratory initial project. And what that did again was give us the opportunity to bring together all of the behavioral health organizations and participate in figuring out what it was that we needed to be looking at. And this, I think, laid the foundation for this idea that unless we work in a system on an ongoing basis, no one organization, no matter how small or big, is going to make this happen. And so that led us to participate in the Behavioral Health Initiative, which was a huge need for us because I was painfully aware of the need for outcomes, and we weren't doing, with the exception of DISRIP, all of the pre and post testing and evaluations, assessments, screenings that we could. and that we knew existed. It's because it's a training issue and it's a timing issue. And so the PBS has helped us to structure what we knew we needed in a way that we could never have done on our own. And I think this is true for the larger organizations as well, because the larger your system, the more training you need, the more coordination you need. So I don't think it's unique to a small organization. But we have fewer resources, so it becomes very important to us to have that scaffolding, which BPHC has provided, where we are not only given the tools to learn how to make sure that we're doing it in a way that is going to be deemed, credible, because all of these things have certain validity and generalizability, and you have to do it in a particular way. You can't just give people a screening and say, okay, everybody's going to get the PQH9, and if the staff don't know how to do it, if there's nobody following up and tracking it, if there's nobody even just saying, hey, how many did you do? Because we all have so much to do. And so the accountability that BPHC has provided for my leadership is really critical.
Working with Bronx Partners for Healthy Communities has been really powerful for us, because not only have they allowed us to expand our Healthy Buildings initiative, but have really been thought partners in thinking about problem solving, troubleshooting in terms of the work that we're doing in the community, whether it's analyzing data, whether it's thinking about an intervention within a building. They have really provided the capacity for us to really address the issues that would keep this program from being a success.
We, for 8 weeks, introduced the pilot to them. We introduced trauma-informed yoga, and then took the time to really see how that was working and what they thought. And we did an informal survey, as well as talking with kind of the team leader there about what people were feeling. And just immediately people felt and saw the connection within themselves of their anger management and their outlook on everything, and found that they found themselves more engaged in recovery because they had this, and they found it just this tool that they were carrying with them as they went along. We did not have trauma-informed yoga before the Innovation Grant. It's something we'd wanted to try. We did a small, really 1 or 2 sessions at one of our domestic violence shelters and saw that it could work. What I think the help with BPHC and the Innovation Grant was thinking about it beyond just another group, and kind of brought some science to it and brought some methodology, so that we had that element of how are we doing this, how are we going to sustain it, how does it link to other things, including measuring if it was working and having a workflow and a plan for how it was all going to work, as opposed to just another good idea of let's try this group, and if people like it, it stays.
The Archcare Time Bank is so grateful to BPHC. With their support, we were able to expand the Time Bank in the Bronx, build a hub there, and also learn how to better report our outcomes. The Time Bank is a free volunteer service exchange network where members help each other with a wide variety of services. They give what they can and they get what they need. It's a great way to build trust, relationships, and a support network. And with the vision that BPHC had, recognizing you need to support initiatives that are innovative and outside the box, like the Time Bank, that really fills in some of the gaps of the formal services, as well as addresses social determinants of health by building social cohesion. So now we have over 250 members in the Bronx, thanks to BPHC.
So our organization has been working with Bronx Partners for Healthy Communities, in particular with the direct workforce, home care workers. And what's been beneficial is that we have seen some great outcomes. One of them being that the home care workers feel supported, they feel like they're being heard, they also feel like they're part of the home care team, and their observations and their involvement is of value to the team.
The CTI program is going into its third year. We have completed 2 years. During the course of that time, CBC's program alone has served over 120 individuals who were homeless and have worked with them through that homeless system and supporting them in their communities. Moving into the third year, we're really looking now at sustainability. We have a project that has proven outcomes, that has really transformed the support that the individuals are receiving, and really adhered and ensured a reduction in usage of ED services and inpatient stays.
When you're responsible with working with individuals in places like the South Bronx with so many health disparities, diabetes, obesity, hypertension, HIV, hepatitis, you sort of just get into the mode of linking people to a service that they need. With CHL, it sort of helped change the perspective. Of course, you're still going to do the linkages, but it's important to also know you can't just make connections and think that that's making the biggest impact possible. You also have to look at the mass people in the community to get them the education so that they understand better of how to access it, why it's so important to access it, how easy sometimes it is to access things that they thought were pretty hard to get. Community health literacy has helped us better serve and stay on the front lines in a way that we didn't do before.
Hello, my name is Loretta Fleming. I am a diabetes peer leader and I have lost 100 pounds.
Hello, I'm Elton Santana and I've been a peer leader here at Health People and educating the Bronx community on how to better manage their diabetes. And me, along with my peer workers, have seen the participants actually improve in the 6 weeks that we teach them. You can see that they have changed the way that they eat, and they do more exercise, and they're more aware of how to self-manage their diabetes.
Thanks, Bronx partners.